Okay, we're going to go ahead and get started. I know folks might still be joining, maybe heating up your lunches. Thank you so much for taking the time to join us today for this webinar that's presented by Shatterproof on our patient experience survey. Just so that everyone is aware, this webinar will be recorded and distributed to our stakeholders across our pilot states following the webinar. So if you have to jump off, you'll be able to catch the end of it in the recording. But we do appreciate everyone spending your lunch hour with us today as we walk through some more information about the patient experience survey. Just a little bit of logistics. All of the phone lines are muted. We will have providers joining at the end of the webinar who will be able to respond to questions, and we'll unmute their lines. So please feel free to send us a chat and we'll flag it for the other providers or for us to respond to at the end of the presentation. If you need anything, you can always use the chat function throughout the time that we're speaking. Like I mentioned, this webinar will be recorded. And again, we're using some slides, so if you're at a computer, it would be great to follow along, and those will also be distributed following the presentation. So to start, you'll be hearing from myself. I'm Sam Arsenal. I'm the VP of National Treatment Quality Initiatives at Shatterproof. I've worked on the Atlas project since its formation and oversee the implementation of the project across our 6 pilot states. And I'll be joined today by my colleague, Shannon Biello. Shannon, you want to say hello?
Hi, I'm Shannon Biello. I'm the Program Manager for the National Treatment Quality Initiatives, and I work with Sam to support her in the implementation of the Atlas program.
Great. So today we'll provide a brief overview of Shatterproof and updates on Atlas, our quality measurement system. We'll spend the bulk of the time talking about the patient experience survey. This is one of the 3 data sources that will inform Atlas. We'll share the results from a pilot of the patient experience survey that was piloted by RTI, our analytics partner, with 50 facilities in the state of New York, and describe how this pilot will inform the rollout of the patient experience survey across all facilities in October. We are lucky to have a few of the facilities that participated in the pilot on the line, and we'll ask them to discuss this process or may have them answer questions. Finally, we will be talking about upcoming Atlas activities. So Shatterproof was founded 6 years ago by Gary Mendel after losing his son Brian after an almost 10-year struggle with addiction. Our mission is to reverse the addiction crisis in America. We focus on raising awareness about the disease and increasing access to evidence-based treatments for substance use disorders. In 2017, we released the National Principles of Care. Derived from the Surgeon General's report, these widely accepted best practices are grounded in substantial research shown to improve patient outcomes. Our aim is that care that encompasses these practices is available to those with substance use disorders across the continuum, not that the care is specific to the treatment silo. How do we change the addiction treatment sector and support addiction treatment providers in delivering high-quality care? In order to advance this goal, we have work underway in a number of domains, all aimed at advancing and informed by the principles of care. Today, we will focus on the quality measurement domain, which has led to the creation of Atlas. Atlas is a quality measurement system that is currently in development. Upon launch, Atlas will be a web and app-based tool. The goals of Atlas are, 1, to support people with substance use disorders and their loved ones in locating high-quality addiction treatments, to assist providers of addiction treatment in improving their services and supporting the adoption of best practices, and to facilitate support from states and health plans in making informed data-driven decisions around payment, policy reform, and technical assistance efforts. Atlas is currently being piloted in 6 states before being expanded across the country. This work is made possible by funding from Arnold Ventures, Robert Wood Johnson Foundation, and a coalition of healthcare companies. How do people find addiction treatment? Today, we are focused on the patient perspective, information that is intended to be reported out publicly. Why is this important? We know that increasingly people looking for healthcare services are turning to the internet. Consumers are used to reading reviews for goods and services, and this trend is rapidly increasing across healthcare. Until Atlas, people looking for addiction treatment must sort through a lot of misinformation and in some cases fall prey to services that are ineffective and sometimes unethical. Navigating this system, especially in a time of crisis, is near impossible. We hear this even from experts in the field. So how will Atlas change this? Atlas will assess program quality at the facility level, including the use of best practices, and report that information to the public to review quality and compare treatment programs, but also to the treatment programs to inform quality improvements on the Atlas password-protected portal available to providers, and then to states and payers to direct technical assistance resources and change policy, as well as to incentivize and support better care. This is the first phase of Atlas, and our plan is to update measures and improve the sophistication of measurement over time. This matters because research shows that when available, patients use these systems to make better selection, and high-quality programs are rewarded, and others are incentivized and supported in making improvements. Additionally, the information gathered from these systems can directly result in improvements in patient care for those that wish to make improvements. This is critical to reach our goal of ensuring all Americans have access to best practices for substance use disorder treatment. We'll go through a quick Atlas recap of the work to date. Atlas is being piloted in 6 states. Those states are Delaware, Louisiana, Massachusetts, North Carolina, New York, and West Virginia. We are working with RTI International as our analytics partner for this project. RTI also supports 5 national health quality reporting efforts and employs a variety of staff with expertise in both substance use research and analysis needed for the development of the rating system. RTI will be manning a help desk during this process and was the group that helped conduct the patient experience pilot. Atlas will be informed by 3 data sources. I know that providers have heard us talk a lot about some of these other data sources, the first being the commercial and Medicaid claims data. The second is treatment facility reporting through our treatment facility survey, which will open at the same time as the patient experience survey. And lastly, patient and family member reporting, which is what we'll focus on for the duration of the presentation today. But first, just a recap on timeline. Looking back, we conducted the National Quality Forum process to inform the measures at the beginning of this year, and have also subsequently conducted treatment facility survey feasibility testing and got feedback from providers during our provider roundtable series. We've been working on updates to the treatment facility survey as well as the public-facing display, which we'll be sharing in the coming weeks through our state engagement leads. Today we're presenting on the patient experience survey, which will open in October. The treatment facility survey and patient experience survey will both be opened on October 14th, so we'll talk a little bit more about that. Providers will have the opportunity to review any information that will go on the Atlas website before it's posted publicly, which is expected to occur in May of 2020. So now we'll walk through the patient experience survey. The patient experience survey questions will be shared following the webinar. The questions are tied to the principles of care. There are 7 questions plus 1 open text response. The questions ask about access to treatment, access to behavioral health treatment and information about other services, overall rating of the treatment program, whether or not their patients were shown respect for what they had to say, and family support, the amount helped by treatment, improvement in the ability to function, and 1 patient narrative question. So now I'll turn it over to Shannon to talk more about the treatment facility or the patient experience survey pilot.
So for Shatterproof to better understand how to gather crowdsourced patient feedback for Atlas, Shatterproof and RTI conducted a comprehensive literature review of articles from 2012 to present on the use of social media reviews for healthcare services. Our findings revealed that while consumer reviews are becoming more common, no articles discuss the use of social media narrative reviews or ratings for addiction treatment. In other areas of healthcare, such as hospitals, narrative reviews capture domains or information not typically collected in other traditional survey-based measures, including quality of care domains and other areas that are important to patient treatment adherence, such as billing, parking, and other services. Narrative reviews can be more meaningful to consumers and carry more weight than overall ratings or quality reports, but at times, the feedback can be cumbersome to report and difficult for patients to process. Some articles also suggest that narratives may not help patients choose high-quality care. Other articles detail that individuals reading reviews will put a different level of value on reviews based on whether they are factual or emotional. Evidence for an association between social media ratings and either survey-based ratings or quality or clinical quality measures was mixed. Evidence for an association between ratings and reviews and higher quality clinical care was also mixed. Our review found that sometimes reviews and ratings on social media sites were associated with higher quality care. And finally, users of online reviews likely are not representative of the patient population. Additionally, many platforms have infrequent or low volume posting of patient experiences and feedback, suggesting low awareness of opportunities to leave feedback. These findings in general inform the design and the pilot of the patient experience survey methodology for ATLAS. Some other key considerations for the patient experience survey methodology from the literature review included, like other social media and ratings platforms, Shatterproof should develop a monitoring protocol to detect fraudulent posts. Shatterproof should also consider monitoring the integrity of ATLAS patient feedback through content moderation. Shatterproof should incorporate terms of use and other disclaimer language. And Shatterproof should identify a threshold for the number of patient responses necessary for reliable data. We will talk through how we incorporated these considerations. We will now describe the patient experience survey pilot and review some of the results. The patient experience survey was piloted at 50 addiction treatment facilities in New York State from April to June 2019. The facilities were identified by OASIS, our partner agency in New York. They included a geographic mix and a range in the size and type of facility. The primary objective of this pilot was to understand the feasibility and utility of a crowdsourcing approach for collecting data on patient care experiences. A secondary objective was to compare the effectiveness of letters versus business cards for recruiting patients to complete the survey. To test this, facilities were randomly assigned to use letters or business cards for patient recruitment. Over the 11-week period, 326 patients completed the patient experience survey, and 25 patients partially completed the patient experience survey. Of the 50 participating facilities, 24 had at least one patient complete the survey. The average number of completed surveys per facility was 6.5, with a range of 0 to 49 surveys completed per facility. There was no difference in response rates between facilities that recruited patients to participate in the PES using letters or business cards. Our aim in walking through the results is to demonstrate how this tool can be used and the types of information gathered, not to make generalizations about the quality of these facilities. The results we present to you here and in later slides are based upon patient feedback at the 24 facilities that had PES responses. It's important to note that, overall, there was a greater variation between facilities than within facilities. More specifically, these findings suggest that patients from the same facility are likely to provide similar responses to PES questions on addiction treatment quality, and a greater variation in patient responses would occur between two facilities. Throughout this presentation, we will also highlight how PES findings may be used to drive quality improvement efforts at facilities. By leveraging the patient experience survey findings in this manner, facilities are empowered to be responsive to patient feedback and demonstrate the value of patient perspectives in their quality improvement work. In general, our patient reviews were positive. When asked to rate their addiction treatment program on a 0 to 10 scale, with 0 being the worst and 10 being the best, the average rating was a 7.96 out of 10. 44% of pilot participants rated their addiction treatment program a 9 or a 10. Among facilities, 7 had 100% of participants rate the treatment program a 9 or a 10. Only 10% of participants rated their facility with a 0 through 5. When asked how much they had been helped by their treatment program, 74% of participants reported being helped a lot. We reviewed these data at the facility level and found that 8 facilities had 100% of patients report that they were helped a lot by the program. Of the 24 facilities with patient responses, 22 had 50% or more patients indicate they were helped a lot by their treatment program. Only 2 facilities had 33% or less patients indicate they were helped a lot by the program. Most patients also reported improvements from treatment. Among those who provided feedback through the PES, 90% of patients reported their ability to deal with daily problems was a little better or much better since entering treatment. When viewing responses by facility, 12 facilities had 100% of patients report being a little better or much better at dealing with daily problems. Only 2 facilities had less than 80% of respondents report being a little better or much better at dealing with daily problems. Like the previously presented findings on treatment ratings and treatment helpfulness, these results were very positive. When asked, when you needed treatment right away, how often did you see someone from this treatment program as soon as you wanted? 58% of participants reported always being able to see facility staff as soon as they wanted. But what does this look like at the facility level? Here we present PES results for this question by facilities. In the blue box, we highlight 6 facilities that had 80% or more patients report that they were always able to see staff as soon as they wanted. Through PES responses, these facilities know their patients positively perceive treatment staff availability. Conversely, in the orange box, there were 10 facilities where 45% or less respondents reported they were always able to see staff. How might these facilities interpret their findings? Upon review of the PES data, we would encourage facilities that have less patients reporting always being able to see staff to leverage this information. Consider strategies aimed at enhancing staff availability for patients as part of your facility's quality improvement efforts. TA resources that focus on this will be included in the resources available to providers through the Atlas portal. Providers may continue to explore other potential areas for quality improvement when reviewing feedback for the patient experience survey question during your treatment. How often do treatment staff show respect for what you had to say? The pilot results show that 71% of patients reported treatment staff always showed respect for what patients have to say. But how do these results vary by facility? At 13 facilities, 80% or more patients indicated that staff always show respect. Feedback that clarifies patients feel respected when interacting with treatment staff in these programs. In comparison, 6 facilities had less than 50% of patients report that staff always show respect. As providers leverage Atlas patient experience survey data to drive their quality improvement work, facilities with similar data trends may consider strategies to enhance staff interactions with patients, lending to higher quality treatment in the future. This is critical because strong therapeutic alliance can lead to increases in treatment retention and improvement in patient outcomes. 80% of patients reported that staff discussed including family or friends in their counseling or treatment. When looking at variations among facilities, 12 facilities had 80% or more patients report that staff discussed including family or friends. In comparison, 3 facilities had 50% of patients report that staff discussed including family or friends in their treatment or counseling. For these facilities, quality improvement efforts may focus on incorporating processes that encourage staff to discuss the inclusion of family and friends in patient care. In future iterations, we have flagged that it will be important to understand how families are involved in treatment. When asked if they were given information about different kinds of treatment services and facilities that are available, 86% of patients reported yes. When we explored these responses at the facility level, 10 facilities had 100% of patients indicate that they were given information about other treatment options. These PES findings illustrate to providers that patients are receiving a wide array of information while in care about their options. In contrast, 13 facilities had 50% or less patients indicate that they were given information about other treatment options. How might facilities use this data to drive quality improvement? Staff, for example, may pursue additional strategies to distribute information on other treatment options to patients on a routine basis. In this way, facilities may incorporate PES findings to implement data-driven improvements to care. This is critical to ensuring that patients are making informed and shared decisions with their providers about care, and that the treatment plan is tailored to the individual's needs, not limited to a fixed set of services, because that is what is available at the facility. Nearly 87% of patients responded to the open-ended patient experience survey question, what is this program doing right? What could be done to improve this program? These responses provide more specific, unstructured feedback on what patients liked and disliked about their addiction treatment program. Overarching themes are presented in the bar graph. As you can see, facility staff, the types of help offered for recovery, and program structures and content were facility components most positively reviewed by patients in the pilot. For facilities, these open-ended responses are useful when exploring what patients perceive as strengths of their addiction treatment program. Each narrative question will be available to providers in the Atlas portal to review once the system is launched. Once the facility has 20 responses to the patient experience survey, these narratives will be posted publicly to help others make care decisions. All responses will be anonymous. Names will be masked to protect patients as well as experts. Patient responses also identify common areas for improvement among facilities, such as increasing the number of services offered and having a more individual focus. As we implement the PES among all treatment facilities for Atlas, providers may use their open-ended patient feedback to pinpoint areas to consider when planning quality improvement efforts. From here, we will discuss how the Patient Experience Survey pilot informed our plans to implement the Patient Experience Survey more broadly for Atlas. And Sam will continue.
Thanks, Shannon. First, following the pilot, we made some key changes to the Patient Experience Survey and its methodology before implementation across all of the pilot states. We added 2 additional questions to the Patient Experience Survey. One question asked about the patient duration of care. How long did they receive care at this facility? The other question asked who is completing the Patient Experience Survey, since we are allowing patients or their family members or friends to complete the Patient Experience Survey on the patient's behalf. An additional change is that we've elected to use only letters instead of letters and business cards to recruit patients. We determined that this method is most practical for facilities as we increase the Patient Experience Survey data collection to providers in all pilot states. The letters are intended to be printed by the facilities and can be left in a common area where patients may pass the letters and determine that they'd like to leave feedback on the facility. We'll hear more from some of the participating facilities about the distribution of these letters directly to patients and how that drove up participation. We'll also continue to use facility-specific PIN numbers during the Patient Experience Survey data collection process as a strategy to reduce gaming. In the future, when Patient Experience Survey data collection is moved to the Atlas website, PINs will become optional. At that time, patients can click Leave a Review on the facility profile to complete the Patient Experience Survey. From the pilot, we also formalized other processes to encourage high response rates and the accuracy of reporting to the Patient Experience Survey findings. As Shannon mentioned, Patient Experience Survey results for a facility will not be posted on Atlas until we have received 20 responses. This was determined to be the threshold for reliable reporting of the Patient Experience Survey. Based upon the pilot, we want to encourage facilities to engage staff in Patient Experience Survey implementation, as well as directly request patients' participation in the Patient Experience Survey. While we don't want to add to workflows or require this, both strategies were shown to improve patient experience response rates during the pilot, and facilities reported that staff were excited about the prospect of demonstrating that they are high quality to the public and gaining feedback from their patients on areas for improvement. To reduce fraudulent or malicious patient feedback, Shatterproof will continue to utilize natural language processing, which will scan all patient open-ended responses and flag any posts that include expletives or individual names. Along with human review, natural language processing is intended to promote the integrity of patient feedback by verifying that published feedback is appropriate and meets certain Atlas terms of use. Atlas is slated to launch in May of 2020. Here we provide an initial preview of the Atlas website. We are excited about the progress we have made thus far and are grateful for your continued support in creating a quality measurement system for addiction treatment. This is the Atlas homepage. This is the Atlas facility profile page. As you know, all addiction treatment facilities in the 6 pilot states will have a facility profile on the Atlas website. These facility profiles will display data from the treatment facility survey, health insurance claims measures, and patient experience survey once the 20 response threshold has been reached. To the left, we provide an initial preview of how patient experience results will be displayed in Atlas. As a reminder, if you do not complete the treatment facility survey, we will still display information on your facility on the website when that information is available from claims or from patient experience surveys. We strongly encourage you to submit your facility survey to publicly display the important work that your addiction treatment program is doing to drive quality improvement efforts so that your profile will be more complete on the Atlas website. Mark your calendars. On October 14th, you will receive a link to complete the treatment facility survey and information to begin the patient experience survey. RTI will send this to the facility contact you provided us. If you did not verify your contact information, please don't hesitate to reach out to us as soon as possible so we can ensure you receive these materials. In that email, you can expect to receive a patient experience survey invitation letter printed in both English and Spanish, which will invite your patients to participate in the patient experience survey and provides the facility PIN unique to the individual facility. Patients can use this PIN to go on and complete the patient experience survey. We will also include implementation instructions for the facility, which describes how you should proceed with implementing the patient experience survey, including optional strategies to engage staff and patients in data collection. You'll receive a copy of the patient experience survey questions, and finally, a frequently asked questions document, which could provide answers to questions that staff may receive about the patient experience survey. However, we did hear back from facilities that implemented the pilot that there was a minimum number of questions and very little confusion about the survey, and that it was a very quick process for patients to complete. As always, we are here to help you and ensure that this process runs smoothly at your facility. If you have any questions during the patient experience survey process, please contact RTI at atlashelpdesk@rti.org or contact Shatterproof at atlas@shatterproof.org, and we'll share those emails as well. Just to flag that many of you may also work closely with our state team leads, who are Rebecca Rosenquist, our lead in Delaware, Massachusetts, and West Virginia, Leah Kaufman, who leads in Louisiana and New York, and Ken Schuslin, who leads in North Carolina. Please always feel free to reach out to your state contact with questions or for more information. We're excited to have a few of the facilities on the line that participated in the patient experience survey pilot to talk about their experience. There are at least 3 facilities on the line, and I just want to go through the questions first. One question before we go through with the facilities. This is only going to be an online survey. There will be no paper surveys at this time. So that was one question. And now I'd like to welcome some of our treatment facilities that participated in the pilot in New York State. First, we have Jacob Colomb, who is the Outpatient Clinical Director for Champlain Valley Family Center. Jacob, are you on the line?
I am.
Great. Hi, thanks, Jacob. And we have your slide pulled up on the screen here. We're hoping that you could share information on 2 key questions. The first being, what was your experience like for your facility? And was it challenging, or what were the aspects of this process that you found valuable? And the second is, how do you plan to use the results when we move to implementation of the patient experience survey for Atlas?
So a little background, the last couple of years I've really been moved into, a data-driven world, really to inform our decision-making and our quality improvement. So Certainly more than ever, we've been looking at data more recently through, Medicaid claims, psyches, and we've always used the perception of care, and we looked at this as another tool that we could receive feedback from the people that we serve. And so when we were asked to be part of it, we were grateful and we were willing, and it went well. So we were provided the letters, and I distributed those letters to our clinical team. Now, we're kind of fortunate in the sense that we're a smaller agency, 10 full-time counselors, and we were asked to participate in the pilot program, and we probably didn't get started till about mid-May. So we had about 6 weeks. So clinicians had the letters in their offices, and when they met with the clients, they were asked to present the letter to our people, and they were given a space at the desk on the computer to complete the survey. It went well based off the number of participants that we had that did the surveys, that completed the surveys. So that was encouraging once we got those numbers back. I certainly took part in that process too, as I still carry a caseload and still work with people. And my direct experience, when people were asked to do it, they were more than willing to take the few minutes. And literally, when I mean it took a few minutes for people that participated to complete the survey. And so very few questions, went off without a hitch. And the information that we got back was really valuable to me as clinic director. So as clinic director, I'm part of our quality improvement team. And when I say team, we really truly work as a team. We get together on a regular basis and we review data and we look and we try to interpret what that data is telling us. Sometimes numbers, there's some ambiguity on what numbers tell us, but very little when it comes to the direct questions that they were being asked with the patient survey. Did we talk about family? Did we talk about including family members? Did we talk about the other services available? Those are pretty closed-end questions where we're going to get a yes or no response. So that kind of information was pretty valuable and is valuable to me. The other thing I think that's important to know, at least from my perspective, is that we fared fairly well in the survey. And as clinical director running a clinical team, it gave me a great opportunity to affirm with our clinicians that we're doing some good work and really motivate and support the work that they're doing. So the ability to recognize that we're doing some really good things, and while there's always room for improvement, we're faring pretty well in some areas. And it also pointed out some areas that we need to improve in. And like I said, that's invaluable information for a clinic like ours.
Great, thank you, Jacob. And actually, I'm going to put you on the spot here. We just received another question from Joe Deegan on the chat feature. Just flagging for everyone, please feel free to submit other questions for Jacob or the other providers or for the team here at Shatterproof. Thank you for your question, Joe. Joe first asked if this was, everyone in the treatment facility, admissions to completed residential, or, anyone. And just to answer that first question, Joe, this is for anyone who comes through the treatment facility. As I mentioned, we will ask how long they received treatment at that facility when we expand the patient experience survey in October. But this is for any folks who see the letter and choose to leave feedback. That said, I know that Jacob's facility was able to direct patients to complete the online survey. Jacob, can you talk a little bit about when and how you guys informed patients about the survey and got them to participate?
Yeah, we did it in individual sessions. So when the client went in and met with their clinician for individual sessions, the client who already hopefully has some rapport with the clinician with the client, they were handed the letter and asked if they were willing, and we allowed them to have access to the computer while giving them enough privacy to answer the questions without feeling like they were pressured one way or another. And certainly, when I rolled it out to the staff, I said, we certainly do not want to influence how people are answering these questions, right? We want to know if there's room for improvement. So that seemed to work well, at least on the pilot program. Moving forward, I think we'd probably reevaluate that in the sense that this would be an ongoing process. For the pilot, I knew that it was there was an ending point. So giving it to the clinicians and asking them to do it during individual sessions, and not somebody that was there for an assessment, not somebody that was there, somebody that had some time in the program. So anybody, the arbitrary number that we chose was at that first treatment plan update. They had been in treatment long enough where they were coming up on a treatment plan update and they could formulate and answer their questions based off some of their experiences that they had.
Thanks, Jacob. I also want to flag, I'm not sure that our friends from Casanova Manor are on the line, Casanova Recovery Systems. They piloted the treatment facility survey in their residential treatment facility, and they were able to actually mention this at resident meetings and just leave the letters out for folks to take if they wanted to complete the survey. So they had staff that were leading the resident meetings, mention the survey, and leave the letters as folks filed out of the meetings. That seemed to work well for them. I also believe that we have some of our friends from Helio Health on the line, Lisa Mancini and Kevin Howard. I'm not sure who might like to respond. I know that they completed the the patient experience survey at Syracuse Opioid Treatment Outpatient Program, which is a part of Helio Health. It's an outpatient program. And I was wondering if you could weigh in on your experience and how you'd like to use the Atlas results in terms of next steps and moving forward.
Good morning. This is Kevin Howard. I am the service director of our opioid treatment program here in Syracuse, New York. We started off this pilot with utilizing the posters that were provided to us to put up in both our waiting room and in our clinician offices. We started off by having all the paper forms endorsed from the frontline staff all the way through the dispensing windows and then further endorsed by our clinicians. With patients that didn't have access to a computer at home, we utilized our peer specialist that took patients to a computer lab that we had on a different floor in order to sit and actually take the survey. We found this to be very helpful on one end, and I know very time-consuming on another end, in the sense of, had we had more peers and our computer lab closer, being able to have more opportunities for responses, we felt that utilizing the time in the clinician's office, we were really just trying to reduce the amount of potential influence the clinician might be able to have for the survey. So we utilized our peer in a remote location to take the test. In regards to the results are always very helpful when you have a survey. We do ongoing assessments of satisfaction for our patients on a regular basis. It's also asked of us by our state providers and accreditation boards as well too, that we're doing this on an ongoing basis. So this was very helpful information to be able to have in a lot of different areas. And we're always working on quality control and being able to offer the best patient experience for our patients. So we find that the survey was very helpful. I think even on the patient level, filling it out, and on the staff level in areas where we're going to be making some changes to improve this care.
Great, thanks so much, Kevin. I'm going to go through the rest of the updates, and then we have a number of questions coming in that we'll repeat and answer for everybody out loud. So please feel free to submit additional questions for either Kevin or Jacob, or for us here at the Atlas team. So just before we move into questions, a recap on upcoming activities. Provider roundtables and state advisory committees will continue through the opening of the treatment facility survey and the patient experience survey in October, and then following that date to ensure that we're increasing our response rates to make Atlas the most useful tool as possible. Also, I know I've said it a few times, but October 14th is when you can expect to receive the email with information about the facility survey and the patient experience survey. If you have not received any emails from us or don't know who the contact at your facility is that will receive this information, please don't hesitate to reach out to anyone from the Shatterproof team. And as we've mentioned in the beginning, this is a pilot process, so we are working to continually refine and improve Atlas. Your feedback has been incredibly valuable as we develop this process and will continue to be so during the pilot. So we always welcome your feedback. Please do reach out to us if you have any comments or questions. And with that, we'll go through some of the questions that we received in the chat. Please feel free to keep sending those in. We're going to start with the question, which is, what is the definition of recovery that Atlas will be using, and is this defined for the participants completing a survey? So to start, we actually don't use the term recovery in the treatment facility survey. We ask about whether or not the patients have been helped by the treatment program, and the responses are not at all, a little, somewhat, a lot, and don't know. And then we ask, compared to when you entered this treatment facility, how would you rate your ability to deal with daily problems now? So we're asking about the ability to, improvement and ability to function versus any definition of recovery in the patient experience survey. We received another question that is, how does Atlas define a facility? This is a great question, thank you. At this time, a facility is defined as the brick and mortar location. We know that some facilities will include multiple levels of care. When you receive the treatment facility survey, if your facility offers multiple levels of care, so you have residential and outpatient available in the same location, there will be the option to complete the facility survey for each of those levels of care if the services and available options are different. So if you use a different assessment tool or only have certain services available in one of those levels of care, you will be able to specify that on the treatment facility survey. You will also be able to report if your facility is part of a parent organization or integrated delivery system on the facility survey. If so, it will be linked on your facility profile so that patients can see what other locations are available in that network. For the patient experience survey, it will be reported at the facility level, so specific to that location. The next question is, how is Shatterproof's patient experience survey going to be addressing unethical business practices, i.e. financial inducement of patients? So the patient experience survey does ask about, what the program is doing right and what could be done to improve this. This is an open text response area, and so if there were to be unethical practices, that may come through in this portion. In general, these patient experience survey questions are tied to specific levels of care to determine whether the facilities are offering best practices rather than to police facilities that may be engaged in unethical practices. If those do come through, obviously that is something that we'll be vigilant to and work with our state partners who are working to enforce those. The next question is the patient experience survey designed to be ongoing or collected during a specified time period? Currently, the patient experience survey that will be fielded beginning in October will be available through February of 2020. So if you leave those letters out through February of 2020, patients can go on and leave the feedback on that website. That feedback, once 20 responses are received, will be available on the Atlas website. Atlas website will include the option to leave feedback on a facility, and this will be available in an ongoing fashion. We will retire posts after they've been, after 1 year of being up for other patients to review, just to ensure that the responses are timely. So right now we're focused on this initial implementation period, which will be from October to February of 2020, and then following that, we'll be moving to the crowdsource approach, where we would still hope that facilities would promote this to patients. Another question is, can data be separated by multi-satellite locations? So this does tie back to the answer about the facility location and how that's defined. If a facility is part of a integrated delivery system or a larger parent organization, the responses should still be specific to that location, but patients will be able to view the other locations in that integrated delivery system through the ATLAS website. There's also a question about the outpatient setting. This facility sees both individuals with substance use disorders and mental health diagnoses. Will we only collect information from those with substance use diagnoses? This is a great question and something that we'll need to ensure is specified in the disclaimer language that ATLAS is intended to gather information about treatment for substance use disorders. It does seem like our questions have been slowing down. We'll stay on the line for a few more minutes, and thank you so much again to Jacob and Kevin for sharing your experiences during the pilot, and to everyone else for taking the time to listen in. If you have any questions, please don't hesitate to send them now in the chat or send a follow-up email, and then we would be happy to address those. So Mary Pearson has asked, once 20 responses are available, the data will appear and then it will get updated as more come in. That's correct, Mary. So once the facility has 20 responses, those will turn on the facility profile. So you'll be able to see what other patients are reporting about this program. As more come in, we'll add those to the patient profile, and there'll be a ticker at the top to say, you know, out of 100 patients, these are the results, or out of 25 patients, these are the results, because the research actually shows that that also helps impact how people looking at the site incorporate and make use of those ratings, and that they tend to find facilities with more ratings as more credible, even if their averages might vary. So another reason why we want to ensure that patients are encouraged to leave this feedback. You know, more feedback is viewed as more useful from patients that may be using the ATLAS website. So thanks for that question. Again, thank you so much to everyone for joining us on your lunch hour today. We do look forward to receiving any follow-up input or questions. Please don't hesitate to reach out to us. And finally, we will send the webinar slides and recording following closing out the webinar today. Thank you.
Thanks.